Excellent. Well, listen, I'll get started. This has been a great session. It's an honor to be here, and excited for this encapsulation of San Diego Shoulder Course. And we've heard some great talks so far. This is going to sort of go through a few of the things that we've seen, but in a different way. So, patient selection and predictors. That's some of the P's that we talked about. Disclosures. The big one here is that I am a small part ownership in an ASC. So we'll talk about some of the kind of winners and losers in this and how that might play into it. And there's some modeling software in here. A lot of people involved in this. Many of them on this call. Chris Clifto, Oki Anakwenze, Daniel Goltz gets a lot of credit for this. Thorsten Seiler from the Duke side, et cetera. Like you can see, it's been really a nice way to work with my Duke colleagues, and excited to kind of take some of the stuff that Chris showed and piggyback on that a little further. So this is not stuff from yesterday, but relatively recent history. So 2021, they took the total shoulder off of the inpatient only list. Okay. And right at the same time, they put it into the bundle. So unfortunately, if you're in the bundle, the only ones that would go into the bundle are the inpatients, and those turn out to be the bundle busters. So this was really not a good thing for people if you were in that bundle, which is beyond the scope of this. 2022, after feedback from relevant stakeholders, I don't know. Everybody's got a different angle on this. It does seem that the stakeholders might have been lobbyists holding actual stakes and having dinners with the CMS folks. But again, depending on your perspective, maybe it's good to have this on the inpatient only list. Maybe it's not. And we'll talk about that here. But basically, they reversed this and they said, all right, we're going to put it back, except these one code, and one of them is a 23472. They announced that those would be phased out, and then effective January 1st, 2024, basically they put this off. They allow this 23472 total shoulder arthroplasty as well as hemiarthroplasty to be done in Medicare patients at ASC. So it kind of whipsawed from inpatient to off the outpatient, maybe back on the inpatient, and then now allowed to be using the ASCs just in the last 5 years. So is this good news or bad news? I mean, it really depends on who you are, right? So if you own a surgery center, this is good news because the facility fee is reasonable. There's some margin. You can do Medicare shoulders in a surgery center, and it seems to be cost effective. If you are a patient, well, we'll talk about that. That's really going to be the thrust of this talk here. What about taxpayers? It's good news. It's cheaper for CMS to do it this way, much cheaper to have the surgery care in an ASC setting versus in a hospital where you have all the bells and whistles that you don't need for the typical total shoulder and healthy patient. What about for hospitals? Well, it's kind of a plus minus, right? You're going to lose some of these cases that used to be, drivers of their bottom line, but to kind of throw them a bone, the government did increase the DRG, what they get paid for those that do end up being inpatient. So I think that makes sense, kind of understanding that the ones that stay in the hospital are probably going to be the sicker patients. It makes sense to pay the hospital a little more for those. What about implant companies? Not good for them, right? This is downward price pressure on the implants. Surgery centers are very, very, very cost conscious. So when it comes to the implant companies, this is going to add to their already pretty robust price pressures. And what about the bundle? I already mentioned, like basically you're taking all the ones that could have made you money in the bundle but the bundle's getting phased out anyway. So that's kind of beyond the scope of this. All right. So how do we navigate the changing policies? And this is something that Daniel Goltz was talking about. So basically, he was talking about the outpatient shoulder arthroplasty, the surgeon as a general manager. You see Billy Bean there from that Moneyball, the great book where you take baseball analytics, you pick the right player, how are they going to fit in the right situation? It's the same thing, right? Surgeons need to operate on the right patient at the right time in the right setting. I think it's really important. So a lot of complex history here. There's a bunch of different studies. I'm going to skip the one that kind of Chris touched on and go over the other two, but there's, as he alluded to, a number of papers, again, with my colleagues here on this call, and you can check it out on Thorsten's website there. So outpatient total shoulder, a lot of literature on this. We just saw some of the great work from the Kaiser Group. The key takeaways is if you have a big registry like Ron and the Kaiser Group have, it shows that outpatient shoulder arthroplasty, they do not have higher rates of readmission, complications, infections, ED visits, or one-year mortality. They do well. Institutional cohorts, so again, smaller levels of patients, but still some of these are fairly large, shows that the complication rates are the same or maybe even lower. So the key thing here, there's a huge selection bias, right? So all those were very like cherry picked patients being taken outpatient, but that's the point, right? You do want to cherry pick. You want the patient to go to the appropriate thing. If they're super healthy, yeah, cherry pick them, put them in the right hospital, in the right surgery setting, in a surgery center where they don't need all that extra, they don't need access to the ICU, 2 doors down, et cetera. All right. So I'll skip this one here because Chris went over this, and I'll go to this one here. So I think the key thing here, the complications win. So who's at risk for 90-day readmission postoperatively? So this was a model that was built, again, with that Duke Rush Shoulder Consortium. And the bottom line is readmissions are expensive, right? So you really want to avoid these. So whether or not you're in the bundle, it's $13K for even just like they hit the door of the ER. You're already looking, in the 5 figures for sure. So this readmissions are expensive. So you really want to avoid those. Marital status is a really big one. So, that goes to the social structure and like who's with these people, how safe do they feel at home? And, a lot of people, even in a big urban city like I am in now, don't know their neighbors that well or don't want to be a burden to them. Or maybe they're not plugged into different, social structures like church or community settings or social clubs, et cetera. So, this is kind of a societal issue that goes well beyond orthopedics, that people aren't as plugged into their neighbors. But the bottom line is if you are married, that is helpful because you have someone in your home that can presumably help take care of you. Alcohol dependence. Again, that goes to, are these people able to take care of themselves? An alcoholic, they're already struggling, and then surgery is going to push them over the edge. Different psychosocial issues like depression, et cetera. Interestingly, surgery, we had a higher complication rate with reverse versus anatomic. And I thought, really, we do reverses all the time? Well, this is clear from the Australian registry. If you look early on, the complication rate for reverse total shoulder is higher than anatomic in the early time points, period. Multiple registries have shown this. So you can debate about long-term, what's the better implant, et cetera, and that's beyond the scope of this. But certainly early on, reverse is going to be high. And probably, again, part of that is the comorbidities, the patient selection, who we're doing it for, what indications we're doing it for. But it might also be things like, instability and stuff that's going to typically cause a readmission. All right, what about going to a facility afterwards? So do my patients need to go to a SNF or rehab? This is something that's important to predict. Like, obviously, those people cannot go to a surgery center. So I want to show you this. This is now over 10 years old, but this is a Wall Street Journal study where they looked at basically if you think going to a SNF or acute rehab is necessary, I want to show you these charts. So when you're in acute rehab or SNF, you get paid by the government per day. So they get a per diem, day 1, day 2, up to day 20. And then on day 21, they get a lump sum payment for all the remainder of the time that they're in that facility. Okay? So that's how it works. And then what's maybe not surprising, but kind of galling, is if you look at center after center after center after center, what they do is they get the lump sum payment and then they kick them out the door. All right. So they hold the patient, they get that 21-day fee, they've maximized their profit, and then the patient's gone. So you could argue if that's ethical or not. I think it's unethical. But I think what it really shows is probably it's not important that they stay each and every one of those days if it's mostly driven by when the check clears from the federal government. All right. The next thing to know is when we look at SNF and rehab, we know it is the primary driver of excess cost in hip and knee arthroplasty. So there's a number of, this is again from the bundling research, but JAMA, New England Journal of Medicine, obviously pretty big impact journals. They show that the only people that were able to save money in the bundle did it by decreasing the use of SNF and rehab. So when your surgery centers come to you or your hospitals come to you, say, hey, we got to align on implant costs and we got to use the same, cement and we got to do X, Y, Z. Yeah, all that's good. That's fine. But what really drives the increased cost is increased use of SNF and rehab. And most importantly, when they decreased the use of SNF and acute rehab, they did not have increased complications, readmissions, or ED visits. So again, I value what our colleagues at skilled nursing facilities and rehab centers do, but for shoulder arthroplasty, it just doesn't seem to be necessary for the vast majority of patients. All right, so again, this is kind of the model here. this is kind of interesting. So marriage was important, whether they were married or not, as I said. Also important whether the married partner was female or male. So if a male patient had surgery, then and they were married, they did well if they were married to a female partner. If a female patient had surgery and they were married to a male partner, having the husband at home was similar odds ratio to having no one to help them, which really is not good for our sex and how much we contribute to the marriage. But basically, having a husband helping you is like having nobody at all, according to this data pretty clearly. All right, so we'll skip through this, but basically, the awesome team at Duke was able to come up with this great model. You could put these variables in, and again, I'll show the website one more time. Very predictive of who's going to need that. So these are the patients you definitely want to avoid in a surgery center. And certainly you're going to want to think about this in terms of bundles and your inpatient stuff as well. But these are the people you absolutely want to avoid in a surgery center, and it has a lot to do with, again, social structure, et cetera. So I think I think the key thing here is there's no clinical decision tool that can completely substitute. We have these models, they're cool, but you really need to holistically evaluate the patient. If you look at them and they've got, and they're having a hard time understanding the instructions and the risk benefits that you're describing in surgery, how are they going to navigate a post-op, at home by themselves? I think the next thing is these models are helpful to identify at-risk patients, get them to the appropriate place, set patient expectations. Also important for liability, right? It's going to protect your decision-making. Why do you send them here versus there? And I think it helps us push back against insurance companies, right? What's important, what's not, right? We need to be able to have the data. The stuff that's not important, yeah, maybe they shouldn't pay for it. But the stuff that is important, we need to make sure that we advocate for our patients to get those type of things. So again, check out this website. At the end of the day, you need to be the best surgeon, citizen, and doctor. You need to minimize your complications. Some of these models I skipped over quickly, but surgery time, blood loss, that's in your hands as the surgeon, right? Are you an efficient surgeon, right? If you've got a bloody field there, yeah, maybe you shouldn't be doing these in outpatient. But if you're able to do it with minimal blood loss, safe, good technique. So some of it, we need to look at the patient, but we also need to look at ourselves. So I also want to give a quick plug for our course in Las Vegas coming up at the end of October. But thank you all for the opportunity. Feel free to check out this. And thanks for all my colleagues at Duke for letting me participate in this research.